Hi, Dr. Wortman. My name is Sharon Carpenter, and welcome to my presentation. So let me share my screen with you. My presentation is over assessing statin-induced myopathy in patients with hyperlipidemia. Elevated cholesterol levels is a problem that many people face and is a pretty commonly seen medical diagnosis. High-intensity statin therapy is currently the recommended treatment to prevent atherosclerotic cardiovascular disease. Due to these new higher recommendations for treatment, providers are also likely going to notice an increase in reported side effects, especially muscle-related complaints. Statins have many proven benefits. Along with a healthy lifestyle, starting statin therapy in patients at risk has been shown to decrease mortality rates. It can be used effectively in both primary prevention and also in patients who have a history of an ASCVD event. Statins have also been proven to decrease both fatal and non-fatal events. Non-fatal events such as stroke can be really debilitating to a person, so preventing stroke and its side effects can therefore also lower healthcare costs. Although these benefits really seem to speak for themselves, there are risks associated with statins that should also be considered. FDA recently released new warnings on the risks of using statins. Some of these potential risks are liver injury, cognitive impairment such as memory loss, new onset diabetes, and muscle damage. Of these risks, muscle complaints such as pain, weakness, and inflammation are really the most common patient-reported side effects. Certain factors can also increase the risk of muscle symptoms. Some of these include comorbidities, decreased kidney or liver function, concurrent use of certain medications, and also advanced age. So let's look a little closer at the occurrence of myopathy. Like I said before, muscle complaints are the most commonly reported side effect, with 10 to 25% of patients reporting myopathy in the clinical setting. However, in clinical trials, patients receiving a placebo actually reported muscle pain just as frequently as those receiving statins. So this suggests that there's probably an overestimation of statin-related muscle pain, but also barriers that are contributing to its misdiagnosis. There are three main obstacles that have been identified when assessing myopathy. Currently, providers don't have uniform terminology or really specific definitions they use when describing muscle pain. They tend to just use broad terms that cover all muscle complaints, which isn't really appropriate for accurate diagnosis. They also do not generally document a baseline assessment before initiating a statin. This can be very problematic when a patient presents with muscle pain during therapy and there's really no starting point to refer to. Finally, there's also a lack of standardized testing available for providers to use for assessment. So the Statin Muscle Safety Task Force was formed to address these barriers and also provide recommendations for patient care. Their first recommendation is a thorough baseline assessment, including current medications and also predisposing factors. A baseline is absolutely necessary to really diagnose true statin-induced myopathy. The task force also gives recommendations for specific terminology to use when describing muscle complaints, as well as routine testing such as pain questionnaires and muscle performance tests for consistent assessment. Really, anytime a patient presents with muscle complaints, a complete H&P should be done, as well as some lab testing depending on the severity of symptoms. So after the provider has made an accurate diagnosis, the task force then offers specific guidelines in the management of symptoms. Generally, if a patient hasn't been able to tolerate one statin, they can usually do pretty well with another. So right now they recommend stopping statin therapy for about 2 to 4 weeks after someone complains of muscle symptoms. Then, if the symptoms improve, a different statin can be started at a low dose and increase is tolerated. Some patients have symptoms with several different types of statins. So in those cases, a long-acting statin that does not have to be taken daily could be appropriate. Ultimately, really achieving the highest tolerable dose of any statin should be the end goal for providers and patients. What we can conclude from this is that it's obvious that statins have major long-term benefits for patients. So being able to accurately diagnose true statin-related side effects and then appropriately managing these will help patients remain on therapy and really get the maximum benefits out of the drug. Here are a few of my references, and that's the end of my presentation. Thank you.